Now, you've all been using biologics. What's your impression as a general group? Are you impressed with them? Do they work? Are they the next big thing? Are they the present big thing?
I think they've been a game changer for a patient population that has driven us, or was driving us, crazy. They've been in our office every other week. We can never get them off oral steroids or going to the ER getting antibiotics for sinus infections they don't have. And because, as John said earlier, we're physicians and we want people to get better. It just, you know, when you see that patient's name on the appointment book, or you get that that call at night, you're like, oh, what more can I think of?
My question is, are we seeing real-world evidence that mirrors what we've seen in the clinical trials? Are we seeing...
I think Don hit it, though. There is a subgroup that it's just remarkable. They stop all their
Well,
medicines.
there's
You
a
have to beg
subgroup.
them to take their medicines.
Right.
There are other people that need to be on their medicines, and there's still a subgroup that doesn't respond as well as
You're
we like.
absolutely right. I like your point. The point is that these patients need to be monitored. They need to be seen back frequently, because in the best world, there are going to be 2/3 of them that do really well, but there's going to be 20, 30% that don't respond to that biologic. And it's craziness to keep them on something they're not responding to. The response in this disease with these biologics usually is very rapid. So it shouldn't be...
Can I just bring in one point which we don't bring? We keep talking about clinical trials. Who is included in clinical trials? Compliant patient. They have to be stable enough to run in period to get included. They're not real-life patients. Your primary
Well, that was his
outcome
point, wasn't
it?
is,
How does it translate?
severe exacerbations, reduction by 1.3%.
So do we have data in the non-compliant real-world patients showing that 50% reduction in exacerbation, or are you only seeing a 20% because they're non-compliant under standard of care?
In the view of the payer, what is the place of biologics? They're expensive. Who gets them? Who needs them? When do you approve them?
Based on the data we have now, we have to... The right patient is the patient that was studied in the trials, similar to what was done in the trials.
But they're not the typical patients. That was your point in the first place.
But when we talk
they're
about
never,
like
they're never
the
a typical
claims,
patient. The antihypertensive medications are never the typical patient.
But these are patients that go to ER, they go to multiple, what do they call, urgent care clinics, they get multiple x-rays.
You're proving my point. So these patients, if you give them a biologic, are you going to change that?
Yes.
All of them?
No, never. In medical school, the
I guess
wrong
that's
answer
the
is
point.
always
That's
never
why
or
we
always.
have to limit it initially now, because we don't have the data to identify the real-world patients who will benefit from these therapies and the ones that don't. As you brought up, it makes no sense to allow this for a non-compliant patient who's not going to be compliant in our ICS lab.
But you've got some data nerds or geeks in
that
can look at all the
right.
costs
So you have
involved
to
in that
demand
patient's care.
that patient be monitored appropriately. I remember when I was looking over claims for WPS, a major insurer, I'd find the only thing in the chart was patient better. I mean, in a biologic that's costing up to $30,000 a year, that's not enough. And so I think there's certain ways to follow these patients. There are certain markers, whether it's ENO, whether it's asthma control test, symptom scores, beta agonist use, work days, quality of life. I could go on and on of the multiple outcomes that you can follow in asthma, but when you're really that sick, necessitating that form of therapy that is very expensive, we probably should demand more in the way of better outcome and follow-up.
But at the end of the day, I can't speak with any robust data to separate one from another. I will tell you that Jeff Drazen wrote a beautiful editorial in the New England Journal and said that these need to be done head-to-head. The problem is the expense of doing it would be mind-boggling. I don't think so either. But the truth is that we're really left trying to tease these studies out, and everybody can argue why one is better than the other.
But what it's done, too, it's ushered in a whole new era. It's pretty exciting because as we have these agents, we're understanding all the different phenotypes. We're kind of going at it maybe backwards. We're having therapy that interrupts pathways, so we see what happens in the end result. So we can relate that to a clinical outcome. What that's called is translational medicine. And that's really big. It's precision medicine with regard to treatment, but translational medicine, understanding, going back and then seeing what genotype it may be. Our ultimate goal is to for every phenotype to relate that back to an endotype that has a physiologic change that generates that phenotype.
Or for the clinician, the right medicine at the right time for the right person. And that's where we are. That's what's so exciting. We finally, I mean, we gave inhaled steroids and oral steroids
That's
for
right.
generations, right? Let's be honest. And now we're talking about understanding subparts of these mechanisms and really attacking them.
We're all talking about pathways. And there's this pathway and this drug affects that pathway. Is there a pathway? Is there a final common pathway and a drug that hits that pathway?
I'm very doubtful, because the one thing I've learned as I've gotten older is that the human body has this redundancy to it. And it has so many ways of getting where it wants to go. And usually to the benefit of us, but sometimes not. Sometimes there's an over, and here we're talking about inflammation. I think maybe we're talking too much about pathways, because one of the biggest difficulties I find is not in there's too much inflammation, but too little communication. So it's not necessarily just a disease of inflammation, but communication.
When you say communication, let me be very clear. Is this cellular communication or physician-patient communication?
Physician-patient communication, because
Thanks for clarifying that.
Because, well, I mean, but the reason I ask
Yeah.
is that if you are interrupting cellular communication,
Yeah.
isn't that what these biologics are doing?
Yes.
But Don brings up a good point. I mean,
Complicated.
part of the problem, and we need to get back to this, a really neat study again by Jeffrey shows that many of the people that we have on biologics didn't take their more standard therapy before. We need to understand why. Was it a communication issue? Was it a lack of efficacy issue? These are some of the things we have to go back and resolve. But also, in answer to your question, Peter, we have newer therapies that are, we call them upstream. So there's TSLP and IL-33. We're going to have to come back and have another conference on that one because we don't have enough data other than one initial study